Okay, welcome back to the final session of this conference stream. For those of you who've been stalwarts of this stream, you'll have seen Steve before. So thank you for coming back for this final session. Steve Kell is chair of Bassetlaw CCG and co-chair of the leadership group of NHS Clinical Commissioners. And Steve is going to talk to us this afternoon about integrated responsibility, patient-centred commissioning. I'm sure he's going to talk about partnerships and all sorts of other things. So over to Steve. As normal, probably 15-20 minutes conversation, and then hopefully an opportunity for a few questions right at the end. But we've got to finish just before 3:30 to allow everybody to come back in for the all-conference session. So over to Steve, but thank you very much.
Thank you. Hopefully you can hear me okay. I'm going to talk briefly about integrated responsibility. There's a lot of talk about integration and what it means. And to me, this is what it means on a local commissioning basis. So we talk a lot in Bassetlaw about our role and our responsibilities. So less about provision, less about contracts, less about who does what, but more about holding the system together and making sure that we put the patient at the centre of that. And that's particularly important if you look at the current commissioning system, which is increasingly fragmented. Our role as CCGs and as system conveners, as well as NHS England, I think is increasingly important. So with all of the different commissioners, with all of the different providers in the health system at the moment, can we genuinely provide commissioning and services that puts the patient at the centre? Well, we have this. I walked into my practice manager. Yesterday I was back in reality. I was doing a surgery. I walked in my practice manager's office and was amazed to find this pinned in a prominent place on her wall. And I think that she had this as a reminder of how the new system looks. Well, I can't really follow this. I think it's increasingly difficult. If you're a patient, could you either follow it from the diagram or could you explain it in an easy way as a GP, as a commissioner, as a provider, as to who was responsible for each part? It's an increasing challenge, and I think the diagram just explains quite easily the complexity. So if my practice manager can explain it to me tomorrow morning, I'll be delighted. But it's worked, hasn't it, so far? So the commissioning system in the NHS was fine. Presumably we had social care talking to the NHS, and GPs working hard, nursing homes sorted, quality okay in hospitals. Well, this was news yesterday that most of us already knew, but this was inequalities in premature mortality across England, and we can see there the stark differences in mortality. So people in the northwest, areas around where I work, in the middle, in North Nottinghamshire, significant differences. In my patch, there's a 9-year difference. I'm in a small area, so only 112,000 patients. There's a 9-year difference in mortality, in life expectancy, in my own practice. I have 4 sites, 27,000 patients. There's a 9-year difference between one postcode and another postcode within my practice. So the challenge of holding this together, of improving the system together, and getting commissioning and getting these priorities right is significant. And increasingly we try and see ourselves as a CCG in Bassetlaw as just part of the jigsaw. It's not really, we don't really argue about roles and responsibilities. We try not to argue about this is our role, this is your role, hands off. We have the power to do that. We need to see ourselves as part of a jigsaw working together to improve the patient care. But it feels a bit like this sometimes. So more and more people involved, new people coming in, people separate. I spoke last week at Confederation about the importance of regulation, for example, and the fact that organisations such as Monitor do a great job. They work really well with FTs. Do I, as a CCG lead, really feel that influence? Do I know in any depth the information that Monitor has about my local hospital? The answer is no. So more and more people knowing more and more information about patient care, and yet still we work in separate ways. It's fragmented. And this is what happens if you try and work it out, I think. There are gaps. and it's increasingly confusing. My job increasingly is to stand up in Bassetlaw and other areas trying to explain the system. So I talk to the voluntary sector, I talk to providers, I talk to patient groups, I talk to GPs about the system and how we hold it together at the moment. Less and less about, well, I'm responsible for this and you're responsible for that. Integrated provision takes a long time. Integrated contracting will take even longer. What we need to get at the moment is the integrated responsibility sense, talk to each other, and really put patients at the centre of what we do. We've changed our performance reporting as a CCG. Most CCGs have, to reflect the commissioning outcomes framework. And this does highlight our responsibilities as CCGs. One of them, if I just give you an example, is cancer mortality for under 75s. So this graph shows, since 1971, lung cancer mortality in the UK decreasing in males significantly, increasing slightly in females over the years. This was in a system that had one PCT organising most commissioning. We've got before that, we've got the advent of PCGs, etc. What is the role of a CCG, I would argue, in actually delivering continued improvements? What do patients need us to do to make sure that improvement keeps happening? Well, there are lots of different factors. So as a CCG, we're responsible for ensuring primary care quality. We're also responsible for secondary care services up to a level. So I'm responsible for making sure that if people have suspected lung cancer, they have access to x-rays, they have access to a 2-week wait appointment with a local chest consultant, they have access to diagnostics. But that's only part of the journey. So patients, to reduce the incidence of, to reduce cancer mortality, need, particularly, I'm going to start with public health. So the importance of public health in delivering outcomes that the NHS is responsible for can't be underestimated. I'm concerned that public health is inconsistent at the moment, that they're using inconsistent commissioning strategies, inconsistent procurement strategies, and I feel that is a threat to achieving the outcomes I want for patients in Bassetlaw and nationally. So we need to get smoking right. We need to get people exercising more. We need to get diets right, alcohol, substance misuse. There are so many public health indicators that patients will rely upon, and we will rely upon, if our outcomes are going to be met. Once you've been diagnosed with lung cancer, what happens then? Well, we know that in certain areas, people get less access to treatment. So if you look at my area, we're near a tertiary centre in Sheffield. The further away you are in terms of postcode, the less likely you are to access radiotherapy, less likely to access surgery, chemotherapy. That's really important. It has a number of different factors. So people talk about large hospitals being better. Some of my patients just will not travel. Often they aren't referred to the hospital because we're more distant from that tertiary centre. We're improving that locally. We're working together to make it happen. But still the postcode inequity happens. And when we look at the inequality slide that I showed you earlier, there are so many different reasons for that beyond healthcare. So the specialised commissioning, when people are diagnosed, they then need they need NHS England to work well and to make sure that we have access to radiotherapy, to surgery, to chemotherapy, and all of the different things that go beyond that. And then when they do survive, hopefully, we need to make sure we work really well with the voluntary sector, to work with Macmillan on survivorship. It's a journey, and I think we need to make sure that we as commissioners and as providers work together to make sure that journey works despite the system that we're working in. I've got a patient recently who has been diagnosed with a relatively unusual form of cancer with a poor prognosis. And this was 2 weeks ago, and he said to me, how do I know where to go? How do I know which surgeon will give me the best outcome? How do I know where the patient satisfaction is greatest? Can you help me? And I'm relatively clued up in the system, but I couldn't really help him. There wasn't the information. I rang people, I rang the cancer network. I did as much digging as I could as a knowledgeable GP, hopefully, and it was difficult. And he said to me, I feel, and he's a manager, he's very used to being in control. I feel like I'm on a conveyor belt now, and I'm not sure who's in charge. I had a real role as his GP, I had a role as his commissioner, but I also only had control of some aspects. And this conveyor belt has lots of different parts. This is a quality control system in a factory looking at potatoes. Patients aren't potatoes, but the analogy works, I think, in that this is about who ensures quality in each part of the system. And it was a really powerful message. This was somebody who knew the NHS. He was used to managing data, and yet he struggled with the system. He felt out of control. We gave him no information, and it was a very unsatisfying period as a GP, really. I couldn't tell him more. And that's one of the lessons from the Francis report, this communication aspect, this working together, giving patients enough information. We have a real opportunity. I talked earlier about commissioning support, about the importance of being transparent, about the importance of being honest. When we have issues, so if I have an issue locally, I don't want to stand up on stage and say everything's fine. It's so important that patients know where there are issues, why we're making difficult decisions. If we talk about reconfiguration, let's think about the whole system, and let's make sure it's for the right reason. Let's say if it's on quality issues, let's say if it's on cost issues. We're working together in South Yorkshire and Bassetlaw to make sure that the area team as NHS England, that public health, that CCGs understand the correlation between decisions that we make. So if you look at specialised commissioning rules around population size, any decision that's taken at a CCG level, at a public health level, will have significant effects potentially upon the ability of tertiary centres to provide specialised services, which could increase inequity or improve them. What we haven't done yet is involve patients. That's a gap. We need to do that. And that's what will make us focus on what's truly patient-centred. So this is the system simplified slightly. Clinical commissioning groups, just one part of it. The patient should be in the centre, really. Somebody stood up this morning and said, I'm not that bothered about the NHS, I'm more bothered about patients, I'm more bothered about patient outcomes. So let's make sure that we measure them, let's make sure we can give people information, let's make sure that in 2 years' time, I'm in a better position when I've got that patient in front of me to talk about the best options for their treatment with them. And we mustn't forget primary care. This is a local practice. 3 doctors Wednesday afternoon. I asked them to send me a picture. This is what they sent. We need to remember primary care and the role they play. I'm a provider as well. I have a large practice. The importance of getting primary care right can't be underestimated. It's not in my responsibilities as a contractor, but I do have concerns around NHS England capacity and the transactional nature of future primary care contracting. If we're going to make sure that practices understand what issues are locally, the practices respond to those in a meaningful way, and the patients get options outside A&E, outside hospital, then we need to make sure that we engage primary care both as members and as providers. Because without that, we know that, I said earlier, locally, we know that only 11% of people going into hospital go unnecessarily, but that 70% of people who are in hospital beds are there because there aren't the options in the community for them. So we need to work on that as commissioners. That's a clear message to me as to how we work with patient groups, with the local authority to improve local outcomes. And it isn't all about the NHS. I talked to my GPs on Tuesday about the importance of thinking outside the NHS. When I'm guilty of this. I sit in my consulting room, and for years I've thought about NHS pathways. So I have a patient, for a good example is a child with emotional problems. We tend to think about child and adolescent mental health services. That's what's available. They aren't mentally ill, they don't need that level of input. When you talk to the voluntary sector, there's a huge level of support out there for these patients, for these families. What we're not good at is tapping into that and thinking outside the NHS. Hospitals aren't, GPs aren't. We can improve this significantly, and that would support the voluntary sector going forward. So locally, we're working on a service directory that will help patients and clinicians. We're going to make it based around problems because that's what we come across. There's no point having an alphabetical directory of voluntary services locally if that doesn't link with the description of what they provide, or patients can't find their way around the system. And last but not least, listen to patients. They tell us a huge amount. One of the key, I'm a really keen advocate of clinical commissioning. For me, the strongest part is that when I sit in my consulting room, I need to know that when I refer a patient to another service, I'm aware of the pathway, I'm aware of the quality, and I can have that discussion with patients. Patients then come back and tell me things. The important thing is that we capture that information, we listen, and that as GPs together, as clinicians, as a voluntary sector, that we then act on them and close that loop. That's the really important thing. And without that sense of responsibility, without that sense of advocacy, we aren't going to make the commissioning system work. We won't move to a truly patient-centred system. Thank you.
Thanks very much, Steve. Okay, some really important thoughts there from Steve. Now, we've got about 7 or 8 minutes, I think, to take any questions, observations, reflections. So if anybody would like to make any points, there'll be microphones winging their way around.
Put your hand down. No one's got the hand down.
Oh, there's one here.
Hi, I'm Raj. I'm a GP from Lambeth.
Hi.
We're coming to a perfect storm in terms of reduction in funding in CCG budgets, social care budgets, and provider savings. How can we get patients more involved in telling us what the NHS and social care should provide and not provide? Because I don't think we have an honest discussion with our patients is that we can't do everything for our patients, and that some things we have to not do.
We had this discussion on Tuesday in a development session in my CCG with local GPs, and the 2 key messages were to be truthful. So if there are issues, talk about them. There's a really good analogy in Private Eye this week about the airline industry, about the fact that we trust getting on planes because we know that where there are problems, they're dealt with. It doesn't necessarily apply in the NHS, and I think by being truthful about issues, that will engage them. And the other thing is about information. It's difficult at the moment for patients to get truly engaged because there isn't that level of easily understandable information about local services that will get them there, that will get people asking the right questions. So at the moment, we tend to frame up discussions ourselves about what we feel is clinically important. It's not the same as giving people information and saying, what do you think is important?
Another question at the front. Here, Howard. Could we have the mic over here? At the front, thank you.
It's more of a sort of comment, Steve, from what you were saying just there, and that is that you're absolutely right. We do have to engage patients in these decisions. Being honest with patients is, I think, the best way forward. What we're doing in Bexley is we have a patient council, which is a voluntary group of 25 different organisations that come together under one umbrella, and they have a seat on my commissioning board, so that the governing body, there is always a patient representative there who feeds a sort of two-way process, as well as the lay rep. For public engagement, we have another seat on there. We found that a very useful mechanism for ensuring that patients understand what we're doing and that we understand what patients are sort of want from us. But I think the point you're making, I think we need to make, is we do need to make some tough decisions over what can realistically be provided and what realistically is going to be difficult to provide. But we're not in Bexley in any way getting to sort of so-called rationing yet, but it's not impossible. It could be happening in the future.
But it's about... A local councillor gave me a message 2 years ago when we were talking about a reconfiguration locally. As soon as I took this job, we did a major public review of paediatric and maternity services, which was a baptism of fire. But we did a public review, and at one point he came up to me and he said, we were just starting the review, and he said, look, if this is about money, I'll understand, and we all understand financial issues. He said, if it's about quality, tell me it's about quality, but don't tell me it's about quality if it's really about money. And that's a really key point, I think, about clarifying. People say to me sometimes, your hospital's too small. I think the first question should be why. If we've got better access to services for patients, if we're providing a good quality service and we're financially viable, then we need to question why and not just make decisions based upon what seems right. We need to do things on information, share it with the public, but do it in a really meaningful way.
Any other questions? If not, I've got one. Any reflections, Steve, on the important role that health and wellbeing boards play in this piece? I think I know the answer, but...
No, well, I'm vice chair of a health and wellbeing board in Nottinghamshire, and they're not there yet, I think. And there's a lot of variation among CCGs. There's variation as well in health and wellbeing board, both in terms of structure and in terms of governance. We've just had, for example, a complete change of councillors, apart from one member on our health and wellbeing board. So I've not met them yet. To get that level of consistency amongst different health and wellbeing boards and over a time period to make meaningful health decisions without politicising things is a real challenge, I think, for health and wellbeing boards, and their role isn't clear yet. I do, however, feel that clinical commissioning is the right direction, but working together with local authorities rather than as advisors.
Okay, thank you. There's a question over here. And then we need to wrap up after this one.
Raj from Lambeth again. I was wondering what your thoughts are about using our communities. In Lambeth we're doing work about community assets and connecting our communities up again and then helping us to then be other peer supporters for other patients and helping us to look after our patients with healthy champions in the community. Have you done that in Bassetlaw yet? And
we are doing that. And this comes back to advocacy. So some things aren't necessarily our role, but we really feel strongly that we want to be advocates within the system. So part of that is letting people be their own advocates for their communities. If you like, spreading the message about public health messages, things like that, but also feeding back to us about things that matter. We're a relatively small area. We tend to know our communities quite well. I think the larger areas, there's going to be even more of an issue. And when you look at the difference in life expectancy I described within my own practice, we need then to look at communities within CCGs, within health wellbeing boards as well.